part 1 to 3 of our guidance documents. No, and right now it's the third one. The first one actually is focused on communities, so it's really fit for MHOs, city health officers, um, especially as they set up enhanced community quarantine and also mga COVID centers nila. So it's also to enhance their capacity. But then since we are doing continuum of care and referral network, and because of the needs, we have a guidance also for level 1 and level 2 hospital, and that's focused on palliative, hospice, and bereavement care. And the third one, which is today, it's for levels 2 and 3, but it's a specific topic, because it's focused on triage decisions, shared decision making, and advanced care planning. In fact, it was probably maybe more than a month ago when people begin to ask, like, when you have limited intubation set or limited ventilators, how do you decide who to give? And we hear, well, horror stories, and I'm sure it's very difficult. Even countries like Spain or France, they had to triage whatever equipment or rooms they have because of COVID. So it gives us a lot of challenges actually. And this part 3 guideline, this third part actually has these contents, no? So important are principles and the ethical principles, which will be covered this afternoon. Also, challenges, triage decisions, decision making, advanced care planning. Some of the concepts may even be new to us who are not familiar with palliative care. So it will be a very good opportunity to also learn. Um, we also support, and we would like to inform you that aside from these 3-part guidelines, we actually have other guidance materials that we have shared with our colleagues. So the first part here in the slide, these are related to palliative care. And it includes different pathways that's international. We also have some guidelines from Kerala, India. And a very important part is the ethics guidelines um, that has been developed by UP Manila. So if you click the link where you can also find these guidelines, the link is in the Facebook and the website of the PSHPM and also Hospice Philippines and PSPHP. You can find these references. And we have been involved, PSPHP has also been involved with unified guidance along with Department of Health, PCP, PISMID, and other societies. We have developed these other guidance materials and algorithms that you can see. So we have for primary care, hospital care, also PPE used by health workers. And just over the weekend, we launched the guidelines on return to work. So you can find these actually in the websites of PCP, Philippine College of Physicians, and also PSPHP. You can find more information on this. So we have been very happy to work very closely with different societies, and that includes PSHPN and Hospice Philippines. And you can see the photo here. These are previous webinars that we have conducted. Actually, this one I think just came from last week. So this is the last of this current series, and we might actually do some repeats. We're planning. But we really acknowledge our partners in this endeavor. Maybe the names I have included are not complete, but we're very happy for the support from our colleagues who are palliative care experts. And just to remind also everyone, the document we have here are still provisional drafts. We are currently continuously reviewing these. So it's a living document, no? And especially as we move forward with response, with clinical care and with public health during the COVID, we continuously review and update this. So we hope that maybe in 2 weeks, with more evidence and more experiences, we can have better new versions of the guidelines. And we are disseminating to our colleagues everywhere. and also working closely with unified guidelines and also with DOH so that we can review, improve, and disseminate among our colleagues. So this is my last slide actually, and just to show you that there is actually a hotline that PSHPM, the Root Foundation, and Hospice Philippines have provided. So take note, especially for those in hospitals, you can contact these numbers if you have questions that are very specific to palliative care. We have experts who can guide you. And so that's my last slide, and this is just a closing slide. But thank you very much, and we look forward to this day. In the past in part one and part two, we had almost 100 participants. So we're expecting actually that today we will reach more than 100. Right now, I see already 100 exactly 100 people. And so thank you very much. I turn over to Dr. June Razon, who is the president of Hospice Philippines. He will introduce our speakers, and also he will be the moderator. So over to you, Dr. June. Thank you very much.
Thank you so much, Sir Lester, and thank you, PSHP, for the support in this great endeavor. So, good afternoon, everyone. So, I am Dr. June Razon, and I will be your moderator for today. So, this afternoon session is the final leg of the three-part webinar series, as explained by Dr. Lester. So, this is very important, particularly in this time of the COVID-19 pandemic. And I guess most of the attendees here are affiliates of healthcare facilities. So this is a good avenue for learning for everyone. And it is my privilege to introduce to you our esteemed speakers for today. So let's start with our first speaker. She is Dr. Karine Estepa Garcia, who is the current Vice President of the Philippine Academy of Family Physicians. And she is also the President of the Philippine Society of Hospice and Palliative Medicine. Also, she is the Chair of the Department of Family and Community Medicine of the Manila Doctors Hospital. Also, she is part of the training core of the Hospice and Palliative Medicine Fellowship Program of the UP-PGH. And then our second speaker, he is Dr. Rojim Sorosa. He is a medical specialist 3 at the Southern Philippines Medical Center. Also, he is a faculty at the Davao Medical School Foundation College of Medicine. And our last speaker, she is Dr. Rumali Corvera. She is the Vice Chair of the Department of Occupational and Family Medicine, Asian Hospital and Medical Center. She's also part of the advisory board of both the PSHPM, Philippine Society of Hospice and Palliative Medicine, as well as the Hospice Philippines. She is also a member of the 19th Council of the Asia Pacific Hospice and Palliative Care Network, and currently she is the Executive Director of the Root Foundation for Palliative and Hospice Care. But before we start the lectures, may we invite everyone to key in their questions on the chat box so that our speakers could answer their questions on the latter part of this webinar. So without further ado, let us all welcome our first speaker, Dr. Karine Estepa Garcia, as she discussed a little bit of the background. Sorry for that. A little bit of the background and general principles of healthcare challenges in the COVID-19 response. So
Okay.
thank you. Go ahead, Ma'am Kay.
Okay, so thank you, Dr. June. Okay, let me just share my slides. Okay. 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 Okay, so thank you for that introduction, and welcome to all our participants for the part 3, the last segment of our provisional guidance for palliative care. Okay, so as was discussed earlier, okay, this part 3 consists of 8 major topics, and the three speakers will divide these topics. Okay, so I'm tasked to give you these first three as outlined here in my slides. Okay, I'll provide you with the background. Okay, and why and who should use these guidance documents, the general principles and the responsibilities of our healthcare providers, and the healthcare challenges in the COVID-19 response scenario. Okay, so first of all, why did we develop this guidance? Okay, the part three, why was it developed? Okay, first of all, because of the need for a realistic and uniform process of communication. It will all boil down to communication in the context of this present COVID-19 situation, okay, and its effect on the human and medical resources, okay. So I'm talking in particular about setting of goals of care, okay. This would also include processes of shared decision making and processes of triage, okay, for the intensive care treatment. Okay, so a greater part of which has been adopted from existing international guidelines on the ethical framework for decision making, because it's important to have a decision guide for advanced care directives, and also when do we need palliative care, specifically in this COVID situation. Okay. So, who should use this guidance? Okay, okay, so sino po ba sa atin? Okay, so of course, healthcare professionals, including doctors, nurses, and hospital management from level 2 and level 3 hospitals with COVID-19 patients or other patients facing life-threatening illnesses. Okay. Okay, so and then knowing about who to use, who would benefit this and why was it created, we need to consider what ethical principles are involved. Okay, so marami yan, but there are 6 cited with this triage decision making or shared decision making. Okay, first of all, we're talking about equity. So when we talk about equity, available resources are to be allocated without discrimination. Okay, so the decision should be made in such a way that we have to ensure that a few people or possible become ill during or they die. Okay, so the allocation of such resources or the procedures must be fair, objectively justified, and most importantly, transparent. Okay, next. Okay, so what ethical principle is? We're talking about preserving as many lives as possible, okay, under the conditions of acute scarcity, and all measures are guided to be aimed of minimizing the number of deaths. Okay, third, okay, protection of the professionals involved. Okay, so utmost protection for professionals, including have to address the physical and psychological stress that it involves here. Okay, so fourth ethical principle, okay, is the right to information on health status. Okay, this is very important and sensitive because the patients really have the right to determine, and they also have the right to refuse the information. Okay, we know that every human being, okay, will have different histories, okay, and we all have different sets and or collections of fears, concerns, and values. So when we consider providing information, it has to be tailored to the needs of the patient and taking into consideration the values, okay, yung religious, ethnic, linguistic specificity of the patient and the family. Okay, so fourth ethical principle that this guide that is used here is the right to informed consent. Okay, so the right to access all information that might enable him or her to actively participate in the decisions regarding health. Okay, so healthcare providers, okay, are to provide information relative to treatment, including the risks involved, okay, the discomforts, the side effects, and possible alternatives. So that's about informed consent. Okay, so what about patient autonomy, or we're talking about self-determination? Okay, so the requirement, what I discussed earlier about the patient's consent, okay, or for the consent of the individuals, okay, for treatment, protects actually three ethical principles. Okay, so from harm, which is your non-maleficence; benefits, this is doing good; beneficence; and respect for autonomy or self-determination. Okay, so providing the information about advantages and disadvantages of any, okay, proposed treatment enables the patient to reflect and deliberate on whether or not to refuse the treatment that is offered. The key here is actually a regular communication with the family and the patient to review goals of care and advanced care plan. So I've discussed the six important fundamental ethical principles that is applied in this that were applied in this guidance document. Now let's go to what are the healthcare challenges in the COVID-19 response scenario. There are three unique healthcare challenges. Okay, so first is the duty to plan, okay, the duty to safeguard, and the duty to guide. Okay, so what about the duty to plan? The key here is uncertainty. Okay, so healthcare leaders have a duty to plan for the management of foreseeable ethical challenges during a public health emergency. So ethical challenges arise when there is uncertainty about how to do the right thing in clinical practice when duties and values conflict. Okay, so this planning for these foreseeable ethical challenges include sometimes identification of potential triage decisions, including the tools and the processes. Okay, and these triage decisions might come into decisions about level of care. Are we doing ICU, medical ward? What about initiation or withdrawing life-sustaining treatment? These are sensitive issues. Even referral to palliative or comfort-focused care, and concerns specifically of shortages of staff, space, and supplies. Okay. Next is the duty to safeguard. Okay, supporting workers and protecting the vulnerable population. Okay, so the facility have the duty to respond to public health emergencies by safeguarding their healthcare workforce. Okay, specifically in this COVID scenario situation that well predicts deteriorating environmental conditions and heightened risk of occupational harms. Okay, lastly is the duty to guide. Okay, this is interesting. Okay, we're talking about contingency levels of care and crisis standards of care. Okay, so a severe respiratory illness such as COVID-19, okay, can will be requiring the need for ventilator support for patients who are in the ICU. Okay, so this would entail monitoring of trained staff, your intensivists, your ICU nurses, including respiratory therapists. Okay, so everybody will be focused on that. Okay, but ICU beds and staffing are already, or hope sana hindi naman, becoming scarce resources, specifically during a surge of critical ill patients. So sometimes mafi-fill up na talaga ang available beds natin. So it will all boil down to the shortage of staff, space, and supplies. So ideally, what we do is first come, first serve basis. Okay, but in this kind of situation, okay, the approach for allocating critical resources can be varied. Okay, so sometimes these critically ill patients waiting for an ICU bed, okay, might be of benefit for if from this resource, if for a compare if there is already a patient in the ICU but is not improving. So how do we go about it? Okay, so that's why a hospital or health system's institutional ethics services is warranted. Okay, bioethics consultation. Okay, they should function as resources for clinicians experiencing uncertainty and distress under under these abnormal conditions. Okay, so I think that's the end of my part. I will now go give the floor to Dr. Rojim Sorosa, who will discuss the next part or the content of the part 3 guidance. Thank you.
Okay. Thank you very much, Dr. Estepa. So if you assist me, you'll be in charge of the slide projection. So there you go. So good afternoon, everyone. And my topic will be about triage decisions, shared decision making, and we'll discuss algorithms involving shared decision making, conversation guide, patient family physician communication. And I'd like to share also the pathway that we made in order to provide family care and psychosocial support to all our critically ill, suspect, probable, and confirmed COVID patients who are admitted in the intensive care units. Next slide, please. So, what about triage decisions? So, as a general advice for triage decisions, these are patients requiring intensive care that are to be admitted and treated within established criteria. So for COVID facility centers, uh, at this point in time, I'm sure they already have their own criteria for those patients who will be admitted in the ICU. So triaging, it's a process of determining the priority of patients' treatments by looking at the severity of their condition or likelihood of recovery with or without the treatment. This triaging is also a process of which requires preparation of a triage system um, to best allocate resources, critical care resources, in order to meet a severe surge to maximize benefit for the greatest number of people. Triage policy implemented by clinicians trained in triage or senior practitioners, and they're complemented by clinical decision support systems. And they aim to identify patients with such a low probability of survival and that they are unlikely to benefit from ICU care. So part of this triaging process is to identify those kind of patients too. And so I have come across with an article written by Mabes et al. About the different operational steps to implement a triaging system within the ICU. So there must be inventory of potential ICU resources for a surge in demand, establishment of identification triggers for initiation and triage. For instance, if you have an elderly patient with several comorbids, elderly patient with multiple medications, patients who are severely disabled, and these are trigger points to which you might be able to initiate more critical conversations, such as the need for advanced care planning, the need to tackle issues about directives, the need to tackle issues about aggressiveness of medical care. So all these things are important triggers, especially if you know the data in your institution and the kind of patients you are treating and are managing. So, and then this also entails preparation of a triage system, which should be there should be interdisciplinary collaboration, and in doing so, there should be agreement on a triage protocol to target resources to those with the greatest incremental benefit. and consideration of changes to allow limits to the delivery of life-sustaining measures in times of crisis, and indemnify against litigation for decisions made in accordance with triage policies, and incorporation on the standards of medical care. So that means looking at the PSME guidelines, our local guidelines, in order to uh, look at management that can actually benefit our patients admitted in our own treatment facilities. Also, family care and societal support, healthcare worker support, and also we have some pediatric considerations. So next slide, please. So the role of the triage committee is to apply the criteria for ICUK, an assessment of mortality risks using sequential organ failure assessment score, your SOFA scores, which determines the probability and likelihood of morbidity and even mortality for those patients who have a tendency to go into sepsis and then eventually to septic shock. And then also, of course, to revisit all these decisions over time, especially for ventilated patients, and to come up with collaborative decisions to include patient and or family in these decisions, so that you can revisit these decisions and change your goals of care as the need arises. And so therefore, there is a need not only to communicate within the interdisciplinary team and all the other extended team members, but also there is a need to communicate this to the family. So next slide, please. So, and this is the importance of which is for us to be able to incorporate what we call shared decision making. So shared decision making, as defined in this guidance document, is a key component of patient-centered healthcare. It is a process in which clinicians, patients, and families work together to make decisions and select tests or treatments and care plans based on clinical evidence that balances risks and expected outcomes with patient preferences and values. And we have done this with our patients admitted in the ICU, granting that all these patients are in the stage of major therapeutic efforts. And sometimes there might be questions where families begin to look at whether or not these aggressive treatments will benefit their patient or not. And we make advices and at the same time try to collaborate with the attending service and see whether or not it is the right time to talk about prognosis or otherwise. Next slide, please. So what are the key concepts of shared decision making? So this entails, of course, good communication. And sometimes when we are not trained to communicate, or when we have difficulties in communicating to our patients and to our colleagues, this could lead to conflicting goals of care, especially if the patient is being cared for by multiple services, a lot of members of the team, and notwithstanding also the family that they're into. And sometimes these families have extended family members, etc. Patient autonomy as much as possible should also be preserved. So in all these particular circumstances, just like our experience with dying patients, with patients who are critically ill, as much as possible, we give them that sense of control. And they should be able to actively participate in the decision-making process. And this gives them a sense of empowerment. Decision-making should always be patient and family-centered. Next slide, please. So the recommendations of this guidance document includes the active training and education to healthcare workers. There is a need for interprofessional collaboration and increase the capacity to decision-making, to invite the family members and to be able to give support not only to the patient but to the rest of the family members as well. And also, we need to check if everyone is on the same page, because if they are not on the same page, then otherwise this is something that's going to create problems in the future. So the tools to evaluate if the patient correctly understands the information. So we have specific tools for that. For instance, we have the CEA approach, in order to correct any emotionally critical misperceptions or misconceptions about the care for these patients. So shared decision making is also used for advanced care planning. So as long as there is a common framework, then we can make the goals of care as a whole and collaborate effectively with the rest of our colleagues and to the family members. Next slide, please. So here is the Annex B, which is a shared decision-making conversation guide. So this conversation guide allows us to have a common framework that we can work upon so that our conversations to the patients that we are taking care and to the family members, immediate family members, are the same. So we invite them to participate in the discussions. We present different options of care. It is very much like the informed consent process where you present the benefits of the intervention, the risks of the intervention, um, the likelihood of progression if these standards of care are not followed, and at the same time, alternative courses of action. So therefore, in using this approach, we are able to balance whether or not the risk outweighs the benefit or the benefit outweighs the risk. So in this process, we assist patients in evaluating options based on their goals. So we have to be prepared if, for example, patients would really want aggressive and maximal care. I will show you. I will share to you later on the data that we have when we collected, when we recorded all the referred cases in our treatment facility. Because in this particular scenarios, a lot of these patients are in the stage of major therapeutic efforts rather, as compared to patients who are suffering from stage 4 cancer or end-stage disease. This is something that's sometimes acute and very sudden. And then to facilitate deliberation and decision-making process and assist patients to follow through on that decision and then revisit again, monitor and evaluate the responses and the effects of that decision and try as new information is gathered. Next slide, please. In Annex C, which is entitled Patient and Family Physician Communication Guide, it's very important that the family and the patient should feel that the support coming from each and every one. And this, I have been very, very consistent in telling all the residents, the consultants, so that the patient does not feel abandoned, especially when you say that the prognosis is very, very poor. So ensuring comfort by communicating to the patients from the beginning, during, at the end is very, very essential. So you ensure comfort by addressing the person, using the person's name. Do not call them the case. Do not call them the case or patient number 2655, something like that. So address their names as much as possible. You also need to assess emotional temperature. You don't know, you might be opening a Pandora's box. So it's very important to ask questions. How are you feeling today? How have you been feeling in the last 24 hours? Are you comfortable? And then when you begin to ask these open-ended questions, you have to actively listen. So this means that you need to use your active listening skills. And active listening skills requires you to listen with compassion. And in this kind of scenarios, when you try to listen to your patient, sometimes we have major roadblocks that may entail the following: judging the person, criticizing them, or name calling because they're not able to follow your suggestions. You suggest solutions so that you can actually simplify your communication by means of ordering or excessive inappropriate questioning. And then sometimes we avoid the conversations or the person's concerns and we divert them to other topics. So these are roadblocks that we need to address as soon as we listen to our patient's concern.
Yung in-order niya food
The other
panda.
one is we need to
Yung isang
reassure.
pinapakuha ko. Please daw kami.
Okay, so there's a noise interference, so maybe request the other mics. Especially if you have new things in the medical management, new things in the patient's clinical condition. Always ask the question, so what do you understand now? What have been explained to you by the doctor, by the nurse, by the rest of the team caring for you? And deliver information with empathy. So this means you need to avoid technical terms and use very simple terminologies. If you're delivering a bad news, give warning shots. I am afraid that I have bad news to say to you today, and this entails about, and this is something to do about your medical condition. So things like that, and to use your senses to look at verbal and nonverbal cues. A patient might actually say they are okay, but when you try to look at their facial expressions, they're not okay. So then we have to use um, statements to support their emotions, their feelings, and to provide support as well. Next slide, please. So in my last slide, in the second to the last slide, this is a decision algorithm that we proposed um, to the infectious disease experts and all the rest of the core team about how to provide family care and psychosocial support for the critically ill patients who are suspects, probable, or those with confirmed positive case, patients. Next slide, please. So this algorithm is about accessing family care and psychosocial support. So if they it does not follow that when you cannot see them face to face, or you cannot touch them or visit them personally, it does not mean that you cannot provide support. I would like to emphasize on that, because everything here that we did was to communicate to our patients using the best of technology, using mobile phones. We use a messenger, etc., only to provide emotional and family care support. So, but before doing that, we try to elicit as much information as we can in order to understand the overall clinical condition of the patient. And once we're able to do that, we begin to initiate family and psychosocial assessment using family assessment tools, using communication tools, etc. And once we are able to determine the needs and the goals of care, we continue to provide the care, support them the best way we can, and revisit and change the goals of care if there is new information. And if this is meeting the family's needs, then we continue to provide until they're able to go home or be discharged from the ICU or be discharged to a step down facility. And we provide more, especially if, for example, we know that this patient is deteriorating, and so therefore we use other hospice care related strategies to initiate end of life care discussions. Just to give you um, uh, examples of what we've experienced in the majority of our patients whom we've handled in Southern Philippines Medical Center, those who were referred to palliative care and family medicine for support. Majority of these patients are in the stage of major therapeutic efforts. And then, well, since these are all critically ill, so um, we only got to contact them in a small fraction of the cases that were referred to us, but almost 100% we were able to establish and contact the family members. And by the time they are able to reach the ICU, almost 70% of these patients do have advanced healthcare directives. And we are very glad because sometimes the residents, when they were trained or they received continuing medical education for palliative care, they are able to initiate such critical conversations. And so majority of these patients have advanced healthcare directives. Um, and majority, since these are acute, sudden conditions, potentially irreversible, but maybe life-threatening on one end, majority of these family members and patients have expressed a full code status plus supportive management. And in these patients, majority of the patients that we were able to talk to reported distressing physical symptoms. That's almost 80%. So majority of our palliative care interventions were mostly physical interventions. There's one patient of ours who was initially admitted to ICU, but was discharged from the ICU and then eventually in the step down facility, and she was very anxious. She was very anxious. She had palpitations, although she was diabetic, non-hypertensive, and she was very anxious and she couldn't sleep at night. And so, if we were not able to pick this up, her quality of life could be severely impaired, even though she's in good hands already. But the experience of distressing physical symptoms can be very, very problematic in terms of affecting the quality of life. So this patient received benzodiazepines, and she had very good and positive responses. And as a matter of fact, she's doing very well right now. So we were also able to elicit families' predominating concerns. And majority of these concerns, in contrary to patients' concern, which is mostly physical in nature, majority of the families expressed emotional, psychological issues and practical needs. I'd like to share with you, there's this two patients of ours we've cared for, and this patient had a very simple request inside the ICU. She was a CKD5 patient undergoing regular hemodialysis, but because she was physically weak and she said to us she was dependent on her husband, a simple request was made to open the mineral water and to open the food that was prepared to her, because she had no strength to do all these things. So if these would not have been picked up, it could severely impair her quality of life while staying inside the ICU. So we had to call the nurse in charge, talk to the resident on duty to attend to the practical needs of this patient. And then eventually when this patient died, the family was at a loss as to what to do next. So we had to do a lot of collaboration. So it's mostly social work services to guide the family members where to put the body next, how to coordinate with the funeral services. We've done this also to our pediatric patients, since 50% of our census were also coming from the Department of Pediatrics. So issues like this, as my ending statement, are very important to us because, for one thing, these are not normal, the normal things they experience, because staying in the ICU without the family members at your bedside can really trigger a lot of existential issues. And if there's one thing that's most feared about by a lot of persons, even if you ask yourself now, what's the worst thing that could happen to you when you face your own death? It's actually dying alone. And so when conditions like this progress and there's no point of no return, then we should do all in our knowledge, in our capacity, in our skills to make the person's experience as favorable, as dignified, and as peaceful as possible. And that is the essence of providing palliative and hospice care to patients afflicted with this virus. So that ends my talk. Thank you very much.
Thank you so much, Dr. Sorosa. And now let's all welcome Dr. Rumali Corvera for the last part of today's webinar. Go ahead, Ma'am May.
Hi, good afternoon. Good evening now, actually. Give me a second to share my screen. One moment.
Okay, while waiting for the slides are now shown. Thank you.
Here. What is actually all right. So for my segment, we will now corner in on advanced care planning and it will lead us to a further discussion about goals of care. And I think the real question here now is, how do we integrate all of these interventions, these communication interventions, into our pathway, for caring for our patients. Now, we must admit that our present pandemic has been the trigger for patients now expressing their need for more information. And this is just to share a statement from the Philippine Alliance of Patients Organizations when there was a review and meetings regarding ethics during this COVID time. And in this statement, the patients with severe COVID-19, they they realized that stay in the ICU could be as short as just 1 week, and then there would be experiences of rapid decline, especially after these patients were intubated. So all the more there was a need, and all the more there was a need to already discuss what they would consider advanced directives or DNAR for these patients, even upon admission, and not to wait until rapid decline were to be experienced in the ICU. And there was even this in this statement emphasizing that even before admission, the information that should be relayed to patients regarding COVID and its uncertainty should already trigger discussions about advanced care planning or directives. So this is straight from the patients themselves. Now, just to share very simple definitions first for advanced care planning. Now, it's really making decisions about healthcare, and it is in the face of a medical crisis. Now, these decision making and its planning is really a process, no, and it's not just it could be more than just a one-time sit down type counseling, and the decisions that are to be made during this advanced care planning procedure should really be based on the person's values and preferences, and even discussions with loved ones. Now, the involvement of family in advanced care planning cannot be undermined. No, it's really advised that a patient or anyone of legal age, able to make decisions for themselves, should already have a say. Now, as early as actually in the 1970s already in the U.S., advanced care planning was already put into a motion to be legislated. And the tools were already crafted. So it's been nearly 50 years now in our more developed countries that this approach to patient care has been already made as a law. So in the US and then in the UK. So the American family physicians also recognize this, and as an ongoing process that each patient has the right to do and to have along with their care provider. And they simply defined it as, like I said, an ongoing process, and it would be translated into the action wherein a form would be filled up, and that form would contain the results of their advanced care plan, and that form would be called an advanced directive. So later on, I'll also explain that there are different types of advanced directives, but in our case now, in the phase of the pandemic, we now are seeing more disease specific advanced directives forms that have been crafted already nationally by ethical bodies. So there is another way of just looking at what this advanced care planning is all about. Simply put, again, it's just planning for the what ifs. And we know that there are many uncertainties throughout lifespan. This whole COVID is one whole unprecedented uncertainty, and we are still learning more about it. And there are so many what ifs now for the past 2 to 3 months. And as Dr. Lin just simply put it, these can be discussed, these what ifs. So even if I am a patient, or if I'm not a patient yet, but I know that I could catch COVID-19 just by simply going to the grocery store now that our quarantine has been modified and partially lifted. So again, we need to face this reality. So what if I, a healthy female in my 50s, contract the virus? What if my immune system is not strong enough and I am rushed to the emergency room? Would I want to be intubated? What would determine my decision? What would be my chances? How strong am I to overcome the virus? So these are specific what ifs for COVID. But even before this COVID pandemic, life itself already has many what ifs. And the essence of general advanced care planning is really facing that reality that we can already voice our preferences if we are faced with a critical decision. Whether we are sick or well right now, we have that right. And that is done and it's expressed through advanced care planning. So as I mentioned earlier, there's two main types: the general advanced care planning, and like I said, it can be made by anyone who is healthy. So in the US, it's actually a process that is encouraged by any adult 18 years and above. They are actually encouraged to make their own advanced care plan. So mas common ito sa states, no? Most of the states in the US already have documents or flyers or brochures available for most in health clinics about advanced care planning. So whether you're sick or well, you would have access to this information. And then of course, there's what we would call a disease-specific care plan. And this would be perhaps for particular illnesses, of course, like a patient diagnosed with cancer. Maybe in the cancer center, there would already be information about how to plan forward for how you would want your care to be. Of course, there is your curative measures, which would already be part of your care plan as guided by your doctor. But as early as maybe stage 1 or stage 2, cancer patients in our more developed countries are already made to think, what if chemotherapy doesn't work? Until what point would I continue? For example, in the case of renal patients, how long would I want dialysis? At one point would I say no more dialysis? So these again would be specific, disease-specific ACPs. And later on, because our topic and because all of us are now facing this COVID and all of its uncertainties, nationally we have already been seeing advanced care planning specifically for COVID-19 patients who are hospitalized. So I will share that later. Now this third one, preferred plan of care, is usually in line with what we would call hospice patients now. It's usually designed for those who have a prognosis or not expected to live beyond 1 year. So this is very specific now for how they wish their care to be within the life expectancy that they have now been assessed to have. So this is more specific for hospice patients, a preferred plan of care. So this all can be documented, like I said, in the form, which is an advanced directive form. So in order for the planning to be complete, no, these are the elements. No? Ito yung dapat kasama dun sa pag-uusap. And the first one, of course, is to make sure that the patient has a mental capacity. And of course, we know that there are certain principles in determining that. And if they are deemed able to make their own informed decisions, you proceed. But if not, of course, you need to have a special power, a surrogate decision maker who will be alongside them to communicate or to address, communicate in their behalf. And now, what should come after determining their capacity is giving of information. So this is where we now see the importance of the triage. No? What type of information should be given at triage? Now, it is already well made public. No, what type of pattern we could expect for severe pneumonia and COVID. If the patient does come in with signs already of moderate to severe pneumonia, the factors that could um, affect survival should already be discussed. At the same time, they should already be made aware that there may be a point that they would need invasive ventilation. So these types of life-sustaining treatments have to be explained already at the triage. Now, um, the information, of course, must be handled very gently. Also assessing, like Dr. Im was sharing, you need to really get the emotional temperature of the patient. We know that this is easier said than done, no? So that is why the role of our triage, or those um, in the admitting point, at the admitting point of care, no, should be well versed in communicating this type of information, yet being very sensitive to the individual's emotions as these are being explained. Now, another element is helping them decide. So after having given the options and saying this is our treatment plan, we also need to make them aware that this treatment plan could also change from time to time depending on their response to treatment. And you would need to also give them, you know, um, information on what could be the next treatment escalation. So having explained that, you would also help them decide what type of treatment they wish to have or wish not to have if they were at a point of um, if they are already at a critical point of illness wherein they would be prognosed to be have uh, already distress or failure, primarily pulmonary failure if in the case of COVID. So we have to actually gently usher this topic in when we discuss and help them decide. And you have to give them, answer their questions, answer their fears. And if there are certain questions that we may not be able to directly answer, we should also be honest enough to say so, that this is uncertain, we cannot be sure. So we have to really walk alongside these patients, if not personally endorse them to the team that will continue to be communicating with them as treatment escalates, or even if it as it improves. So both ways, that is the role of the healthcare team here, to walk alongside in these types of decision-making points. And of course, we want to encourage our patients to share their own values to us and, of course, to their loved ones. Okay, so what's challenging, of course, now with our COVID scenario is that loved ones cannot necessarily all be with the patient. It's usually just one family member. But then to keep those telephone lines open, we have patients, of course, who have their own phones. Some phones can have videos, so they could still communicate. And we do encourage that that continues when they are admitted. And even if they're isolated, we make sure that their lines for communication are open through technology. So they are still able to share their values with their loved ones, even if they're not physically present with them. So when would some of we would say, so doc, if they are given this opportunity to decide a triage, for example, an elderly patient with signs of moderate and potentially severe pneumonia, and then they decide that I do not want to be treated with life-sustaining, but relatively healthy, coming into your emergency room, walking and talking clearly, but then they are short of breath. And you see the sign already, and that they are categorized as moderate to severe, possibly severe pneumonia, and they tell you, Doc, I don't want anymore na if ever na kailangan mag-intubate, do not anymore. And maybe they would decide already then and there. But what if in the progress of their treatment, we do see signs that they are improving with antibiotics, but they do need uh, more aggressive respiratory support. And perhaps the doctor may deem that, oh, the heart is still strong. Um, it could be discussed again, and life-sustaining treatment could still be considered if we do see better, if there is signs of improvement, or if the attending team would say mukhang kaya to, no, with more aggressive ventilatory support. I think the heart can sustain and overcome this infection. So the initial plan of care, or maybe the initial directive, can still change. So it's not written in stone. No, no. Once you plan already and have a directive, doesn't mean it cannot change. But so there are times you really have to review your advanced care plans, no, with your patients and with their family. So in other cases, no, perhaps for non-COVID, some of these um, directives may change if you change your place of residence, or even in the perception of their quality of life. Or let's say they're in the cases of cancer, no, if there are new therapeutic options, care plans can change. You might want to try a new drug, whereas before you said, oh, no more, I don't want chemotherapy anymore. But then there are new options. So in this case, I remember also sharing my own advanced care plan, where initially I thought my final hours would be would be better at home. I said, okay, I think I like the idea of really spending my final hours at home. But being in the practice and seeing how families are better supported in a hospital setting, I actually changed my plan. I said, okay, I think for my family, I would rather that my final hours be spent in the hospital, but yet the goal would be best comfort measures. At least my family there would not have to worry about directly caring for me, but rather they would be there for me more for my emotional support, while the hospital team would take care of my actual bedside care. So like I said, these can change, no? And my aim now is to make sure that my family has optimum support in my final hours. So that could also happen. Now, so for advanced care planning, these recommendations would be as follows. Now, just to summarize, all critical care teams should have basic understanding of advanced care planning. No? And this is actually why we are sharing this guidance document also this evening, is for healthcare professionals, our colleagues, to embrace the importance of sitting down with patients and talking to them about their preferences and values. And the importance, like Dr. M shared, regarding decision making, that we should give them opportunity to express what they would want. Give them opportunity first, of course, to understand what the options are, and at the same time decide along with them. And if they cannot decide for themselves, to be there to give them recommendations as medical professionals. So that's why our colleagues in the triage, in our consultants in the ICU officers, they are now, I'm seeing them now more and more be understanding how to implement, no, advanced care planning and directives among patients and families. And of course, for patients that lack capacity, um, critical care team should inquire about any possible existence of an advanced care plan. So for example, in the private setting, we may have foreign patients that already have accomplished their own, kasi it's quite standard na in other developed countries to have your either living will, no, or your own advance directive already prepared, no, and even notarized. So for foreign patients, for patients who have been perhaps diagnosed with a chronic illness, na baka naman napag-usapan na rin nila to at na-document, our responsibility as healthcare providers should be to ask if meron, no, baka they have already expressed that. There's actually it's also said that you can have a verbal directive, no, as long as there's a witness in some countries, but ideally it should be documented. So the pandemic situation, of course, we've seen this, that it is a serious but acute illness, and it should be given priority now to introduce advanced care planning to our more fragile, especially our more fragile patients in the community or citizens in the community. Although this planning is noted to be should be very individualized and not just sent out to the community like saying lahat dapat na more than 60 years old or 80 years old dapat mag-advanced care plan na kayo, no? It should not be presented like that. It should be very individualized, recognizing the individual's right to express their preferences, whatever age they may be. And if they are not prepared to share, it's okay. What's important is the healthcare system gives them opportunity and access to advanced care planning through healthcare systems, no, and hospitals. So the process of advanced care planning, sometimes the attending team will not be prepared to really sit down. So this is the time where palliative care providers who may have been trained in advanced care planning, counseling, or even bioethics consultation teams could be called upon. So I know, of course, not we only have a few hospitals in our country that have palliative care programs. We are still growing, and we are still hoping to enable all our government hospitals to have palliative care, which would help. But in the absence of that, you could either refer to bioethics consultation team if the attending team themselves cannot um, sit down with the patient to go through what we would call advanced care planning. So we were asked earlier. I noted that there was a question about at what point or what is the best time for this shared decision making. So we were able to come up with this algorithm. So in the attempt to demonstrate, how shared decision making, advanced care planning can come into the picture. Now, this is taking off from algorithms of our colleagues in PSMED, PCP, wherein we initially would have to categorize our patients as being moderate or severe risk pneumonia or mild. But in both directions, whether you're admitted or not, as you can see, let's go to the arrow for those with moderate or severe risk. Once you're admitted and you are a patient who is capable of decision making, the recommendation here is the attending team facilitates shared decision making. Um, if with if the patient is not capable, with the substitute decision maker. Now, once shared decision making, meaning sharing the possible treatment plan, also the possible complications of the pneumonia, and once this shared decision goes to the point of they are asked to consent, of course, for their treatment, for the medications, which now we know are some are off-label. It furthers on into giving them scenarios just in case treatment needs to be escalated. Would they want ICU care? Would they want life-sustaining measures or invasive ventilation if it is needed at one point? So this communication is facilitated early on. And if the patient would still desire full life-sustaining treatment, again, the goals of care, as I will share later, should also again be discussed, no? And that would lead them to the point of checking if advanced care planning is now appropriate at this point for the patient. Now, if advanced care planning can now be discussed, you sense that the emotional temperature, the patient is ready to talk about their decisions about life-sustaining measures. If the patient, if the team can refer to a supportive and palliative care program or service in the hospital, if it's available, that can be done already so that advanced care planning can again be well discussed with the patient. But if there is no service, supportive or palliative care service in that hospital, the attending team themselves should facilitate advanced care planning and continue caring for this patient through the palliative care approach, meaning focusing on best symptom control and, like Dr. Rogem said, psychosocial and spiritual support for the patient and for the family. So just a footnote, like I said, why Doctora, why do you have to ask if it's appropriate or not? Dapat, diba, sa lahat? Again, it has to be individualized. You have to determine if at this point the patient is ready, especially when you're faced with a very symptomatic pneumonia. there's a lot of emotional stress already. Are they willing to walk through what this decision making? And if they are, that's when you can initiate that if it is appropriate. So, of course, though, we know that it's particularly important for those who are elderly and frail and have other serious comorbidities. Okay, but like I said, I emphasize that it is made on an individual basis according to need. This is just to validate that statement about it being an individual, made on an individual basis according to need. This joint statement was made by the British Medical Association, their Care Provider Alliance, because like I said, there were general statements that all elderly should have advanced care plan, when in fact it really should be made on an individual basis according to need. So we cannot emphasize that enough. Okay, so going to the actual form. This is the form that will document what was discussed in the advanced care plan. So basically, these would be the elements. Of course, they're um, the situation of the patient, and then the medical interventions that they wish that should not be administered, and medical treatments that should be considered. So these would be listed down in the form, or if the form is already formatted, for them to either tick, or I'll show you the example of this form later on. And now there would be consent. In some forms, they would give you the opportunity to say if you would like to participate in research or not. And then, of course, the consent or non-consent regarding resuscitative measures. And then in the particular form I will share, there's also instructions for palliative care that the patient can be oriented or primed about and given the opportunity to indicate that they would want palliative care. So I was mentioning that there is already advanced directive form crafted, that it was included in these ethics guidelines. So you can actually go to this link for the full ethics guidelines on COVID-19 that was prepared by the UP study group. And the annexes would provide you an actual form for advanced directives specific for COVID-19. So these are actually both in English and Tagalog already. So you can access the form in this document that's made available already to us. But we were given opportunity as a society and as palliative and hospice community to review this form, and we were able to and allowed to integrate palliative care principles and the palliative care option into this form. So this is the version wherein palliative care is included. So I won't walk through each of these slides. I'll just quickly run through them to show you the elements of this available form, which is in our guidance document. So this is specific for COVID-19 hospitalization. So again, an advanced directive template for patients admitted for COVID. And basically, it states the awareness of the situation. So of course, the admitting officer, her doctor, would have to explain. And the element of stating who their substitute health-related substitute decision maker is part of that form. And then the main part one would go through the different treatments that they wish or do not wish to have done if they were to show signs of rapid deterioration. So these interventions would include invasive ventilation. So they are given that opportunity to decide that if they would allow or not. And then even vasopressor support, inotropic support, if they would allow or not. So take note, these are presented to them after the treatment plan has been laid out and the prognosis has also been discussed, and the chances for recovery have also been discussed with them, complications explained. So they are walked through this. The idea is to walk them through these decisions. If they still wish to have CPR, if they do reach this point wherein life-sustaining measures are required. And even dialysis. So we do know that many COVID patients do go into cytokine storm and may require dialysis. So they are also given the opportunity to decide if they wish or do not wish for dialysis or blood transfusion. Part 2 corners in about life-prolonging interventions, and they are asked to tick one of these if they wish to continue all life-prolonging interventions, or if they wish to discontinue it if it has been started, or for some patients, hindi talaga, they cannot decide for themselves. So they would rather have their doctor and another healthcare provider decide for them. So either one, no, either of the three should be discussed, no, and decided on by the patient. And lastly, in this form particularly, is the option for palliative care, that they know that if life-sustaining interventions also will not already be in as a decision, they would not wish for life-sustaining, they still have the option and stated clearly here that they would want care in the form of palliative care, meaning comfort from distressful symptoms, and including psychosocial and spiritual care for them and their family. So this form basically allows them to express that as well. Okay, so what's interesting is this is a form that also needs to be experienced, no, and piloted. And some of our palliative care specialists have actually tried going through this form with some of their patients. And I just wanted to share this quote kasi kahapon lang din to na-share sa akin, because when I was sharing about advanced care planning, it is not going to come across to patients the same. No, some get it right away, some may not, and sometimes you really need to make it simpler. So in this particular case, ang pasyente to ni Dr. Pedro, who is a palliative specialist, was asking, Doc, hindi ko to maintindihan. So what Dr. Pedro simply did was dinaan ko sa kwento. I'm quoting from how she relayed this to me. Dinaan ni Dr. Pedro sa kwento, no? Not directly asking from the paper, but hypothetical questions na like she did. She said, paano kung mamaya mas hirap ka huminga? Anong naisip mo gawin? So even though we have this form, like we said, we have to know our patients and how well they will be able to understand it. And sometimes we really have to interpret it in a more simpler way, and perhaps not by documenting it in the form themselves, but in the chart as to their reply. So that is another way to document a directive. It may not necessarily have to follow the form, but if you are able to elicit their preference in a language that is easier for them to understand, you can actually document verbatim, no, what they have said in the chart. So you can write what they have said to you in the chart, and it can also be witnessed. So the form is not hard and fast, and you have to really have a form, especially if hindi naman ma-absorb ng pasyente yung elements ng form na yan. So there another way to document their directive. So going just quickly through goals of care discussion. Also, continually there should be review of goals of care. Is the medication working? Goal pa ba natin to yung full recovery from this pneumonia? Mukhang oo, kaya, no? But let's say tomorrow biglang the nagdidisat ulit, and then the patient is an elderly. Let's see again, is this still possible? What are the chances of recovery at this point? So we have to have these same page conversations na tinatawag. And we say if cure is no longer feasible, that may no longer be a realistic goal. What now is our goal? So the goal, of course, for palliative care is to continue best comfort measures, to make sure that this patient still gets adequate psycho-spiritual care and social care. So whether it be through technology, allowing them to communicate. Sometimes in our own institution, we also have communication boards. So kahit naka-intubate or mildly sedated yung patient or naka-intubate, but they're still able to identify, and connect with figures or letters on the board, they're still able to communicate what their preferences are. So keeping in line with the patient's wishes is basically what goals of care discussion is. And it's not just, again, done once. It's done actually for more critical patients on a day-to-day basis. What we say to our families is, we're taking this one day at a time. Tingnan natin kung okay yung ating treatment today, if it's effective, no? And like we said, mandatory for any medical intervention, of course, is the medical indication. And that has to be well explained. So why are we doing this? They have to understand the patient and the family. And again, all of these discussions and decision making should be patient-centered. And if treatment limitations should be determined, these should also be discussed honestly with our patients, so that goals would remain realistic, at the same time patient-centered. So this guidance document just gives a simple algorithm for treatment goals and decisions. Ang maganda lang dito in this algorithm, it shows us kung sino yung dapat magiging involved or responsible first to discuss, for example, the definition of the treatment goal. The doctor, of course, should be the one to discuss this, and the patient should give input as to their own goal. But it is alongside the team and the family. Now, when explaining the indication for a treatment, of course, the doctor should explain the indication, and the team should be there to understand. About patient information, it's the doctor, again, who should give this information to the treatment. And when we're at the point of discussion of patient consent, the patient should really be involved, expressing their content for this, their consent for a treatment, and the team alongside. And of course, at point of interventions, the team is responsible is the physician and patient, along with the team and the family as part of this process. And take note here, in the evaluation of treatment, the patient is still partly responsible alongside with the physician. So the physician would have to ask the patient, so how are you feeling, no? Maganda bang effect ng gamot, hiyang ba sa'yo? So not only do we assess clinically, but we also ask the patient how they are receiving the treatment, no? And understanding how its effect on them. So it's a cycle wherein these goals are examined, no? And if there are negative results, you start from the top again and say, this isn't working, so what now is our treatment goal? Okay. I think the bottom line of all this is to be brave enough. Like, this is one of our favorite quotes, that we all should be brave enough, especially as healthcare providers, to initiate these conversations that will really matter. And these patients have the right to have these conversations with us. I know we are in the forefront of a war right now with COVID. And sometimes we say, wala nang time makipag-usap ng ganito kahaba. But mind you, that's why we have to work as a team. Now, if you in the front line are in charge of rapid intervention, should be someone alongside you in charge of decision making and working with the patient and family and talking with them. So it has to be done as a team. These conversations cannot be done by one person alone. It has to be brought to the forefront in patient care by a team. Well, just to share, if you'd like to connect further with us, we did start a Facebook group, and this is open. We are opening an invitation for you to join. And this basically will connect us as healthcare providers along with our specialists who can answer more questions regarding the provision of palliative care. So you may look up, and if you want to join this Facebook group under Palliative Collab. And tonight we will also be announcing that the website for Collab is also open out to the public. And this particular website is really aimed in establishing compassionate communities alongside our palliative care providers and other stakeholders. So this is also the site where these guidance documents will be uploaded. And like we said, and Dr. Esther said, these are living documents, no? So as revisions come, the more recent version of these guidance documents will be uploaded to this website. At the same time, there are other references in this website for those who are really into providing palliative care. And this website will not only give you guidance, but also inspiration, hopefully, to continue working alongside us to build up compassionate communities. So this would end that's my segment. Thank you, Dr. June.
Thank you so much, Dr. May. So thank you so much, speakers, for sharing your expertise with regards to the COVID pandemic that we're facing. And I think we learned a lot, ranging from the use of the guidelines, from the ethical consideration, also the collaborative effort between the interdisciplinary team, shared decision making. Also, we learned a lot about advanced care planning. So I think it's the perfect time to entertain some questions from our audience. So we have the first question. Could you give examples of um, uh, actual scenario encountered personally or secondhand to better illustrate the principles? So could you share a little bit of that?
Sige, ako na lang.
Sige
Hello?
ma'am, go.
Okay, so in general na lang, even in non-COVID situations, so that they would understand how we can apply the ethical principles. We have to consider that the clinical situation also, and when you know at that point when is the timeline or the prognosis of the patient. So typically I encounter this ethical or what you call this principles in the situation of a collusion. Okay, so when we talk about family collusion is wherein they would tell you that I know my mom, I know my father better than you, so please do not tell anyone yet. Okay, I don't want him to be in more harm. So if we're looking into ethical principles of autonomy, okay, so does the patient actually need not to be told regardless of what the family would say? This is talking about self-determination. And if we don't tell, okay, would it do more harm or do more good to the patient? Okay, so I think that's a simple example of how we can apply this, how these ethical principles are seen in actual clinical scenarios. Okay, but the solution for this is actually to have a discussion or a family meeting in both sides. Okay, the family and the patient as well, as to discuss. We have to determine what's the issue here. Bakit ayaw sabihin? Why? What are the concerns of the family? Okay, so I think that's one way of that's an example of it.
Yeah,
Thank you, Dr. Kim.
Dr. K, may I also interject and add something to what you said?
Mm.
So usually we ask the person and the family's communication preferences.
Mm-hmm.
Unlike in chronic diseases, sometimes you experience this collusion. But in instances where you deal with acute diseases like this, for instance, in COVID, when you ask them, so how much information would you like us to know or would you like us to divulge to you? Most of the time, these patients would respond to you together with their families, Doctor, tell me everything I need to know. So that approach alone eliminates now what Dr. Estepa has stated earlier about the problem of medical collusion, which is very common in the Filipino families or in our setting.
Thank you so much, Dr. Im. And for the next question, I think this is directed to the two doctors here, for Dr. K and Dr. Im. It's about, the question states, since government hospitals have been assigned by the government to take charge of majority of COVID-19 cases, does the DOH as health leaders have the responsibility for identifying or mandating other hospitals, including private facilities that non-COVID indigent patients can turn to for their needs? So any comments regarding this question?
Dr. June?
Can you hear me, ma'am?
Yeah,
Hello?
Dr. June. So here, is it okay? So I'll answer the question. Although these are internal processes made by the local government unit, but since the local government unit in Davao City have been updating us every so often, there was actually a move to propose, if okay with private facilities, to partner with them if, for the instance that the facility center will operate beyond its capacity or nearing its capacity, then tapping the private hospitals to accept these overflow patients would be a good strategy. So it was the LGU who initiated the move to partner with them. And also, of course, for instances like this, um, if the arrangement is that the LGU will take care of all the expenses and the cost of care, then I'll take the word of the LGU and I'll admit these patients. So it's that collaboration that's essential also. Although I'm not part of the internal core within the LG and the private centers, but there's ongoing communication about it now. And as a matter of fact, we've identified already 3 facilities that are willing to accept COVID patients, and so these facilities, private centers or private hospitals, are being prepared for that purpose. So that's all I could share on the part of our LG here in Davao City.
Thank you, Dr. Im. Actually, in Manila, even the local government of Manila assigned a COVID-specific hospital. So it's really a partnership between the LGU and the DOH and some of the private institutions. So very well stated, Dr. Im. And then for our next questions, what is or when is the best time to initiate shared decision-making protocols in the case of elderly individuals or individuals with relevant comorbid conditions who are currently stable but diagnosed with COVID-19?
May answer that. Although in the present algorithm that was presented, known as continuing also, of course, to be asked for feedback. No, we we have seen that the ideal time would be um, in the algorithm if upon admission that shared decision making should already be initiated. But what's interesting is when we were discussing the ethical guidance documents, there was a comment by one of our leaders in the geriatric specialty that these advanced care planning instructions, no, or guidance should actually already be brought out to the community. Now, if I may share, in Singapore, like the US and the UK, they already have a law which imposes not on the patients or on the citizens. It's a law that all these laws impose on healthcare systems to ask about advanced directives, about advanced care plans. And it's already part of the system wherein I, as a doctor, or as a hospital admitting section, already should ask the patient. And this is considering that the community already knows what advanced care planning is. So ideally, information should really be brought out to the community, maybe through senior citizens groups, even in churches. Advanced care planning discussions and talks could already start in the community. And this was a suggestion being given by one of our healthcare leaders that our elderly population should already be familiar with advanced care plans, and there should be professionals who are able to share this information with them in a way that is sensitive and informative, and that they will already be able to express what they want even before any acute illness or complications of a lingering chronic illness would happen. So ideally, it should be already informed. It should be public information, especially for fragile populations.
Thank you so
I
much, Ma'am May.
Yeah, I think maybe in connection pala, because there was a question about why is it so difficult here kaya in the Philippines to to really legalize or to have a law stating or mandating advanced medical directives. And my answer to this is because of course we have cultural factors. At the same time, even our religious culture may also have gotten have influence, not bringing this out as a law right away. There are many those who feel that perhaps this patient autonomy is not really in line with the Filipino culture, that we know that our patients know self-determination is not something that is outrightly encouraged. We are very dependent on what our doctors would say, and that's been something that that a patient culture that is very strong ever since. So both patient culture and religious culture. But now we are seeing that these rights for expression should be made known to them and encouraged.
Okay, thank you, Mami. I think we have uh, more time for like two questions. So the next question is directed to the three of you po. Can you give examples how interagency collaborations were exemplified in your institution in the triage system? So may we have inputs po?
Dr. Im, I think you shared earlier as to how patients were already given information early on, and even if they go back home, they have already been prepared to with their own advanced directives. Some of us also who work with home care agencies, palliative care providers doing home care, we also it's also part of our process to discuss advanced care directives. So if they are admitted, we are already the patients that we have interaction with or care for in the home. They may already have that form that they can show the hospital emergency room that this is my goal of care. For example, I'm a hospice patient, but I want to be admitted for best comfort measures. The interagency, whether it be a private home care group, facilitating that documentation of a decision, and on that paper that can be shared to the hospital triage or emergency room. So maybe that's just a very simple example of interagency, in collaboration or a continuation of care for these particular patients.
Okay, so I think we have one more question to be answered. Can we allow at least one or closest relative available wearing PPE to be at bedside for a short period of time of a dying COVID patient, whether it's probable, suspect, or positive? So can you share some experiences in your own hospitals with regards to a patient dying because of a probable case of COVID?
Dr. June, I think I replied to that. I texted the reply, and just to share to everyone, specifically in the ICU setting, it's very strict, and there are safety protocols there. So we cannot allow, but what we can do is what we do are video calls, allowing the family members to see their dying family member, okay, saying their last goodbyes. And in case that this family member, died already, so we have to take care, sana, of these families who are left behind. These families are the ones who would are candidates or at risks for what we call a complicated kind of grief, because it's they did not see, they were not around, they were not bedside during the dying process. Okay, so grief is a little bit different for these kinds of family members, and that I think there is a need to look into this. Okay, grief and bereavement support down to the community level. Okay, I think maybe others would share. Dr. Roji might want to share.
Thank you for giving me the opportunity to answer that. As far as our institution is concerned, we have no guidelines on, if you remember, in the last several days there was a news about a child who died, but eventually turned out to be COVID negative. But the parents were very insistent on visiting this patient because the child had special needs. So sadly, it is a fact that we do not have a policy as of this moment, but this remains to be a challenge until now. We were lucky because when I was invited to speak for the school community, a private school, and then it was attended to by around 120 participants, and there were speakers that are involved in the planning process as far as the LGU is concerned. And so when I did tell them the needs of the families caring for their, with family members admitted in the ICU, isolated in single room isolation facilities, I felt the need to say about the needs as far as the psychosocial domains are concerned. And so when I raised this issue, he said that he is going to relay this request, and I did set a reference on how to create compassionate visiting arrangement. We call that the NHS created compassionate visiting arrangements for their dying patients and those family members who want to say goodbye for their patients. So that remains to be seen, but my next task is to propose a compassionate visiting arrangement to the core team handling the COVID cases in our institution. Hopefully, if it gets approved, then we can institute that guideline or that intervention to make uh, the experience of the families and the patients as favorable as possible. So, but of course, there are barriers, and included of these barriers is the use of personal protective equipment, since the PPEs are used mostly for frontliners. So this remains to be seen. So I'll let you know if these guidelines are approved.
Okay, so thank you for sharing your expertise. Actually, we were informed earlier that many would want to attend, but we've reached the maximum number of attendees during this afternoon's webinar. But they don't need to worry because we will upload the recorded webinars on YouTube and also in our respective Facebook pages. So I think we're okay now, but are there any messages from our speakers before we end this webinar session? Do you have anything to say, Dr. K, Dr. May, and Dr. Im?
Just to thank all those who attended this session, the part 3, and of course to the Philippine Public Health Philippine Society of Public Health Physicians and the Hospice Philippines for the opportunity to collaborate and come up with these 3 guidance statements.
Yes, and likewise, we'd like to thank everyone for coming and for joining. And like we said, these guidance documents are still living documents, and we would really appreciate your feedback. And hopefully we will see a second round. It may not be in this way. It could be possibly videos, instructional videos, but for certain, these guidance documents will be uploaded. And just to encourage everyone here, as healthcare providers, in talking about advanced care planning, we should actually look into our own. And if you have not looked into advanced care planning yourself as a healthcare provider, I do encourage you to do that. Just like to share, I also have made my own 5 wishes already. And this is a general advanced directive that I have myself accomplished. And quoting one of our pioneers in palliative care, Dr. Bayok, she said, "I have an advanced directive, not for myself, but for my family." And so for all of us here, I encourage you to look into making your own advanced care plan. Thank you. Thank you, June.
Thank you so much, Ma'am May.
So
Thank you everyone for joining. Oh, Dr. Im, Can you please say
Yeah.
your piece? Thank you.
Correct. Thank you very much, Dr. June. So thank you once again for giving us this opportunity to share with you our experience in caring for patients with serious and life-threatening diseases such as COVID-19. And well, these are very challenging times, but these challenges should not stop us. Even if you're staying at home, you can still contribute to something. And this is what I usually tell my colleagues, my residents, and my fellows: focus on the things that you can do and don't focus on the things that you cannot do. So even if you are not able to save this patient and there's no going back, but it does not follow that you cannot care for these patients anymore. It does not follow that you cannot care for their family members anymore. So, and focus on that. And when you focus on that, it empowers the patients and the families and makes the process and the transitioning process as favorable and less overwhelming as much as possible. So do not forget to incorporate the palliative care approach to all these patients, not just COVID, but in general to all patients with life-threatening diseases, because this is one thing that's very essential in the healthcare system, and we want our patients to feel that they are being supported using physical means, using the psychosocial dimensions. So the challenge is really up to us. And that I end my parting, those are my parting words. And thank you so much, June, for moderating this conference.
Thank you, Sir Im. Thank you, everyone, for joining today's activity.
Thank you. Thank you,
Thank you,
everyone.
everyone.
Thank you and keep safe. God bless everyone.